Welcome to the educational e-platform for training in neurological physiotherapy of the Faculty of Physiotherapy of the University of Valencia. In this video, we will talk about exercises aimed at improving balance in Parkinson's disease. Balance exercises are based on two principles. One is controlling movement of the center of gravity, and the other is exploring limits of stability. The center of gravity is the resultant point where all the forces of gravity that act on the body are applied. We can assess the movement of the center of gravity by its projection on the ground, represented by the center of pressure recorded on a dynamometric platform. Stability limits are defined by the area in which people can move the center of pressure without losing balance. We have an anterior stability limit, which is the maximum controlled forward movement of the center of gravity before falling. Exercises where we put both issues into practice can be done in quadruped, seated and standing positions. And we can apply a series of difficulties to establish a progression. This progression will be based on the following. First, in the maintenance of the posture. Second, in the change of the patient support base, which is an area created by all the external support points. If we are in a standing position with our feet hip-width apart, the support base is all the surface under our feet plus the space between them. If we are sitting, the support base is the area under the gluteus muscles, but also the space under the feet, if we have them resting on the floor, plus all the space that remains between the gluteal support and the feet. Thirdly, we will consider the proprioceptive alteration of the support base. The fourth point will be to counteract destabilizing forces, that is, disturbing the patient's balance so that he or she must react and control it again. As fifth point, we will add a difficulty, which is giving no sight feedback. Remember, balance is maintained based on three systems: visual, proprioceptive and vestibular. That is, we are capable of maintaining the center of pressure within the limits of stability thanks to the information we receive from these three systems. As a sixth point in progression, we will implement dual task. Dual tasks are tasks where two actions are performed simultaneously. During their development, the person's attention changes from one task to another, which means that when they are consciously attending to one of them, the other is performed automatically. One of the tasks is usually called the primary task, and the other is called the secondary task. In the case of a balance exercise, maintaining posture would be the primary task. The secondary task may be another motor task, like an upper limb movement, or a cognitive one. There are many types of cognitive tasks. A verbal task, for example, would be for the person to say out loud names of animals or the shopping list. A visual task would be to identify different forms of visual stimuli, looking at a clock. An auditory task could be identifying sounds from a recording or the content of a conversation between two people. Also, memory task or calculation task may be applied, among others. How do we bring this theory to practice? The first point of progression was to change the size of the support base. We will ask the person to maintain balance while removing support from the treatment table or the floor. First with the right hand, then change it to the other hand, then one of the legs and then the other. We can make this change intermittently while the person taps the floor with one of the limbs to regain stability. The second point of progression of this exercise would be to ask the same thing we just did, but on a foam rubber. The thicker the foam, the more instability it will give the patient, and the more difficult it will be to maintain balance. For the patient to counteract a misalignment, we will stand on one side and place one of our hands on the opposite hip. We will then apply a destabilizing force, always towards the side where we are located, which the patient must control. If the patient falls to the side, our own body will be there, making it easier to hold her. Depending on the progression of the person with Parkinson's disease, we can apply this destabilization by removing supports. It will be even more difficult if we place a therapeutic balloon under the trunk, since it will increase the degree of destabilization of the patient. We can repeat the previous sequence with the ball under the body. If we also ask the patient to close the eyes, the exercise will be even more challenging. Moreover, if we add a dual cognitive task, such as naming a list of words, we will also increase the difficulty of the exercise. Dual tasks are usually introduced once the patient voluntarily and consciously controls the primary task. So, why do we introduce it? To promote its automation. When the patient is seated, we have more possibilities. The first step would be to maintain an upright posture sitting on ischial support, without any support on the back, with a good scapular position, that is, shoulders back and scapular adducted. At the same time, the feet must have firm and stable support. Initially, we will change the support base by removing the supports under the feet or changing it for an unstable surface. A third step of progression would be to sit the patient on a therapeutic ball while his or her feet are on the ground, and then make the exercise difficult by placing unstable support under the feet. In combination with the sitting sequence, we will add different factors. The patient should begin the practice of counteracting a destabilizing force, which can be the same upper limb task that recruits the different balance reactions, or we can apply it ourselves from different directions from the shoulders. Dual tasks with the upper limbs are very effective for several reasons. In the example in which the patient must be receiving and throwing a ball over her head, she must be counteracting the destabilizing force that is generated when she bends her trunk to catch the ball. On the other hand, when faced with any movement of the arms, the first muscles that are activated are the transversus abdominis and then the posterior muscles to stabilize the trunk and perform hand manipulation effectively. We will ask her that the hips and pelvis should not move on the seat. These dual arm tasks can change from mobility to a non-specific strength exercise, decreasing or increasing the speed of execution. A trunk control balance exercise can be performed on the ball and consists on asking the patient to bounce and suddenly stop, controlling the pose, which requires high muscle control. Continuing with the ball balance exercises, another strategy consists of decreasing or alternating the support of the feet while leaving the hip leveled or straight, without making a lateral inclination. We can make it even more difficult by asking to close her or his eyes. Standing exercises will be performed carefully next to a support, such as a chair, a step ladder, or with the physiotherapist on one side. In standing position, the change in the support base will be given by the space that we will leave between the feet. We will begin by having the feet outside the line of the hips, then at the height of the lines of the hips, and then the feet together, allowing an anterior opening angle of 45 degrees. Changing the support base could also involve maintaining the posture on tiptoe or on the heels. We can repeat this same thing with different foam thicknesses. Under no circumstances would we use a bipedal balance disc or ball in older adults. The next strategy will be therapeutically exploring stability limits, that is, the patient has to control her body and her weight movement without triggering a support reaction of the leg. That is, controlling her body to avoid a fall. Next, we will ask to maintain a single leg support, while touching with one foot in front and to the sides of the body. We can repeat the same thing with a stick between the feet so that the patient has a specific feedback to avoid. It will even be more difficult to do the same, but with a ball under one of the feet and moving it from side to side. We will be behind the patient when we apply destabilizing forces, asking her to counteract the applied force with progressive intensity. We can repeat the same thing in front as well. A second alternative of destabilizing force is to ask the patient to lean on our hands, placed on her shoulders, and suddenly withdraw the support. This second variation can be done by putting tension on an elastic band that we release suddenly. In cases where progression can be advanced and the patient is able to tolerate standing with eyes closed, the added complexity will be adding foam under the feet. Finally, dual tasks while standing have infinite options, manipulating elastic ropes, balls, and group or pair exercises, and all types of cognitive tasks. We can even introduce exercises where the patient must maintain balance while standing on tiptoe, reducing the support base. Thank you for using this e-platform.